Welcome, everybody. Really excited to launch our new webinar series entitled Latest Highlights in Neurosurgical Oncology. We're going to get started shortly, but I do want to thank the AANS for helping us organize these webinars. On behalf of the tumor section, this is an important mission in terms of education for a variety of topics. I want to thank Dr. Yoshua Esquenazi and Kushandra and Chibawanye, who have really worked hard to put together this webinar series. And I would like them to introduce our speaker, Dr. Leomar Ballester. Thank you very much.
Yeah, thank you, everyone. We're very excited. This is webinar number 2. We're going to be doing a long series of these webinars. And Dr. Ballester is our invited speaker today. He studied biology and MD from the University of Puerto Rico and a PhD in pharmacology at Vanderbilt University. He completed residency in pathology at the National Cancer Institute, and then a fellowship in molecular pathology at Baylor College of Medicine, neuropathology at Houston Methodist MD Anderson. He is triple board certified by the American Board of Pathology, Neuropathology, and Molecular Genetic Pathology. In 2017, he was an assistant professor at UT Houston, and then he moved in 2021. He's been an associate professor at MD Anderson, where he holds a joint appointment in the Department of Translational Molecular Pathology. And in addition to being a phenomenal clinician, he's a principal investigator of a research laboratory focusing on the development of CSF biomarkers for diagnosis and monitor patients with CNS tumors. And he's going to be talking about the role of molecular alterations in the diagnosis or grading of CNS tumors, which is exceedingly critical and important for neurosurgeons and for everyone in the community. So, Dr. Ballester, please go ahead. We're looking forward to your talk.
Oh, thank you. Thank you very much for inviting me. It's a pleasure to be here. Thank you for that introduction. So I'm just going to talk a little bit about the role of molecular alterations in the diagnosis and grading of CNS tumors. For the most part, we follow the WHO classification for brain tumor diagnosis. There are 5 editions of the WHO classification. The first edition was written in 1979 by a single author, and we currently are in the 5th edition, which was released in 2021. It was written by a large group of authors with an editorial board, and things have increased in complexity throughout the years. And I'll just tell you a little bit about the most recent framework that we use for diagnosing some of the CNS tumor entities. In 2016, right? So the 4th edition was released in 2007. In 2016, there was a major change in how we diagnose brain tumors. And basically, I like this quote from this article, is that the current update breaks with the century-old principle of diagnosis based entirely on microscopy by incorporating molecular parameters into the classification of CNS tumor entities. So for the first time in 2016, we incorporated molecular alterations as part of the diagnosis of brain tumor entities. Prior to 2016, brain tumor diagnosis was purely based on microscopic examination, H&E staining, and immunohistochemistry. So it was a major change at the time in 2016. We're currently in 2021, the 5th edition, which is what we are using now. And in this update, there are additional changes to increase the role of molecular diagnostics in CNS tumor classification. And we have, for the first time, new tumor entities that are defined by unique molecular characteristics such as DNA methylation profiling. So for the first time in 2021, we have a new tumor entity that's defined by its unique methylation profile, not by its histology, not by the mutation pattern, but by the methylation signature. Here we have a list of tumor entities with known molecular alterations, right? And in some cases, like for example, astrocytoma IDH mutant, the molecular alteration is part of the name of the tumor. So we need to test and demonstrate the presence of that alteration in order to make that particular diagnosis. There are other instances where, for example, pilocytic astrocytomas, we know that they have a characteristic fusion, KIA 1549 BRAF fusion, but that's not part of the name of the tumor. So even in the absence of this fusion, you could still make a diagnosis of pilocytic astrocytoma using other information. This fusion is also not specific for pilocytic astrocytomas. You have the same fusion in other tumor types. For example, diffuse leptomeningeal glioneuronal tumors frequently have the same fusion that we associate with, also see in pilocytic astrocytomas, right? The same fusion. So in some cases, the mutation is very specific for a particular tumor type. In some cases, the same mutation can be present in different tumor types. In some cases, the mutation is part of the name and it must be present to make a particular diagnosis. And in other cases, it doesn't have to be like that. And we have some tumor entities that are defined not by the presence of a particular alteration, but by the absence of mutations in some genes. And the best example of that is this entity, diffuse pediatric type, high-grade glioma, H3 wild type, and IDH wild type, which must, by definition, you must demonstrate that there are no mutations in IDH1 or IDH2 and no mutations in the histone protein. So there are many scenarios that are possible. And in many of these cases, you need to have some form of molecular testing to confirm the diagnosis. So molecular characterization is critical for accurate diagnosis and grading of many CNS tumor types. I'll spend a little bit of time talking about diffuse gliomas and meningioma, which are the most common tumors that we encounter in adults. If you go back to 2016 and look at the adult type diffuse gliomas, these were the options for making a diagnosis. You had diffuse astrocytoma, anaplastic astrocytoma. This diffuse and anaplastic was linked to the grade. We have glioblastomas, we have oligodendrogliomas, we have this category that's no longer in existence, mixed oligoastrocytoma. In the 2021 edition, things were simplified a little bit. We removed diffuse and anaplastic, that's no longer associated with the name. And what we have now are these three options. These are the main three types of adult type diffuse gliomas: astrocytoma IDH mutant, grade 2 to 4, oligodendroglioma IDH mutant 1p19q deleted, and glioblastoma IDH wild type. Right? By definition, it has to be IDH wild type. So you need to have some degree of molecular information in order to make this diagnosis. Now, here we have an astrocytoma IDH mutant, right? If we look at the imaging, the T2 flare mismatch is highly characteristic. It's not present in every case, but this is the first thing I look at when I'm evaluating a case. If the T2 flare mismatch is present, I already know what the diagnosis is going to be. Even before doing the frozen section, before looking at the histology, this is a very high positive predictive value. Diffuse glioma histology, right? We must confirm the presence of the mutation, IDH1R132H expression in tumor cells, shown here by immunohistochemistry, P53 expression, consistent with a P53 mutation, also shown by immunohistochemistry, loss of ATRX expression, also shown by immunohistochemistry. So by immunostaining, we can show the molecular signature of IDH mutant astrocytoma. If you take the tumor tissue and you do sequencing, you'll see the same thing, and that's shown here. All the genes that are listed were analyzed by next generation sequencing, and in this particular case, you have an IDH1 mutation, an ATRX mutation, and a P53 mutation, right? And this is what we talk about when we use this term of integrated diagnosis. You're using information from imaging, histology, immunohistochemistry, sequencing to make an accurate diagnosis. Now, in the case of IDH mutant astrocytomas, alterations in CDKN2A and B, so homozygous deletion of CDKN2AB, inform the grade and supports a WHO grade 4 designation. So in tumors that are WHO grade 2 or 3, by histologic analysis, we must look at CDKN2AB status in order to exclude the possibility of a WHO grade 4 diagnosis. Now, deletions, so the genes CDKN2A, CDKN2B, and MTAP are all closely located in this region 9p21 in chromosome 9. And they're frequently lost together. The deletions that involve the region frequently involve these three genes. So if you actually look at tumors, this is data from CBio portal. These are IDH mutant tumors here. And you can see that shown in blue are tumors that have deletion of CDKN2A. They also have deletion of CDKN2B. And almost all of them also have deletion of MTAP. So these deletions frequently affect the three genes. The same thing is true in glioblastoma. Homozygous deletion of CDKN2A and B is very frequent in glioblastomas, more than half the cases. In the case of glioblastoma, it doesn't inform the diagnosis, it doesn't inform the grade, as it does for IDH mutant gliomas, but it is a very common alteration in glioblastomas as well. Now, there's a question that frequently arises, homozygous versus hemizygous deletion of CDKN2A and B. In some cases, you lose one copy instead of two copies of the gene. Is that enough to make to assign a WHO grade 4 grade to an IDH mutant astrocytoma? And currently, it is not. So hemizygous deletion is currently not official criteria in the WHO for a higher grade designation. It has to be homozygous deletion. However, if you look at the data, this is data from an article, and these two color lines are comparing hemizygous deletion in orange versus homozygous deletion in this darker color. And you can see that patients that have hemizygous deletion have a similar survival to patients that have the homozygous CDKN2A deletion. And this was true in two different cohorts. So there's a possibility that going forward in future editions of the WHO, hemizygous deletion might also play a role in grading IDH mutant astrocytomas. Here we have an example of a 66-year-old patient with a contrast-enhancing lesion in the right hemisphere. If we look at the histology, this is diffuse glioma histology with vascular proliferation. As you can see here, we have necrosis with pseudopalisading of the tumor cells around the necrosis center. Previously, if you go back to 2007, the diagnosis of this case would have been glioblastoma, WHO grade 4, and no additional testing was necessary. Today, under the current WHO, there's a list of about 5 different tumor types that have the same histology, right? It could be an astrocytoma IDH mutant grade 4, a glioblastoma, a Milden glioma H3K27 alter, a hemispheric glioma T34 mutant, or a diffuse pediatric high-grade glioma. So we cannot distinguish between these different tumor types based on histology alone. The distinction involves molecular signatures, tumor location, age of the patient. And that's actually changed some of the things that we can say at the time of intraoperative consultation, because in the past, we were able to make a diagnosis of glioblastoma at the time of frozen section by just looking at the histology. Today, that's not possible because you need to have molecular information. So it's no longer possible to diagnose a glioblastoma at the time of intraoperative consultation because you need to demonstrate that the tumor is IDH wild type. Here we have an example of a 49-year-old female with a non-enhancing lesion. Okay. We have low-grade diffuse glioma histology. So this is hypercellular brain parenchyma with some mild pleomorphism. But we don't see significantly increased mitotic activity, no vascular proliferation, no necrosis. This is what we typically see in lower-grade tumors, the histology. However, when you look at the differential diagnosis of this case today, you see that many of the same entities that were in the differential diagnosis in the previous case that had vascular proliferation and necrosis are still part of the differential diagnosis in this case. So high-grade histology, and in addition, we have some low-grade tumors that you have to consider because you have the low-grade histology, right? And high-grade histology is useful in the way that it can exclude a low-grade glioma diagnosis. However, low-grade histology does not exclude a high-grade tumor because there are molecular alterations that are used to assign a WHO grade 4 in many cases. So today, you do next-generation sequencing for this tumor with low-grade histology. You can find EGFR amplification and a third promoter mutation, and that would be sufficient to make a diagnosis of glioblastoma WHO grade 4. Right. So today, this tumor with low-grade histology, no significant increased mitotic activity, no vascular proliferation, no necrosis, can meet the criteria for a diagnosis of glioblastoma grade 4. There's one more alteration that can be used to support the diagnosis of glioblastoma is combined gain of chromosome 7 with loss of chromosome 10. So brain tumors can be high-grade even in the absence of high-grade histologic features. And that's one of the major changes in the WHO classification in the 5th edition is that now we have molecular alterations that define tumor types as well as grade. So even in the absence of these traditionally high-grade histologic features, we can make a diagnosis of a high-grade tumor based on molecular alterations. Here we have some examples. Right? Diffuse gliomas, IDH wild type, is there's a third promoter mutation or EGFR amplification or combined gain of chromosome 7, loss of chromosome 10. I only need one of these 3 alterations that will support a diagnosis of glioblastoma. You have pediatric type diffuse gliomas, also without mitosis, vascular proliferation, or necrosis in the right setting with the histone mutation. in the lysine 27 or glycine 34, you'll make a diffuse midline glioma or a diffuse hemispheric glioma, G34 mutant, also grade 4 tumors. In the case of astrocytoma IDH mutant, homozygous deletion of CDKN2AB informs a grade 4 designation. So there's a disconnect, so to speak, in some cases between the low-grade histology and the tumor grade supported by molecular alterations. I'm gonna now switch gears and talk a little bit about meningiomas and some of the most recent changes that we have in meningioma grading, where we are also now incorporating molecular parameters for the grading of meningiomas. Meningiomas can occur in a variety of locations, right? These are all examples of meningiomas. One of the first things that I look at when I'm evaluating a case is you look at the imaging. If you see this lobulated appearance or this mushrooming sign, I become highly suspicious that it's going to be a higher grade meningioma, right? A grade 2 or a grade 3 meningioma, as opposed to the grade 1 tumors that typically have this smooth interface with the brain. I wouldn't assign a grade based on this, but I'll become very suspicious that the tumor is going to be a higher grade, and I look for features of higher grade when in the setting of these imaging features. There are 13 histologic subtypes of meningiomas. Here we have some of them: psammomatous, secretory, microcystic. These are all usually WHO grade 1 meningiomas. They can look very different. Here we have an example of a clear cell meningioma. There are some histologic types that are associated with a higher grade. So in particular, clear cell meningioma, here we have another example of a clear cell meningioma, and chordoid meningiomas are assigned a WHO grade 2 based on the histologic pattern. In the past, papillary and rhabdoid meningiomas were assigned a WHO grade 3 based on the histologic pattern. That's no longer the case. Now, papillary or rhabdoid meningiomas are graded as any other meningioma, and we do not assign a higher grade just based on papillary or rhabdoid histology. So when you look at meningioma grading under the current WHO, you have for WHO grade 2 meningiomas, 2 histologic types, right? Chordoid or clear cell, mitotic count, 4 or more mitosis, brain invasion on 3 of these 5 features: necrosis, nucleoli, shearing architecture, small cell change, high cellularity. For grade 3 meningiomas, you can have some anaplastic features where the meningioma resembles a sarcoma or a carcinoma, and that can be used for a WHO grade 3 designation. This is very rare. Papillary and rhabdoid histology is no longer associated with a grade 3. 20 or more mitosis, and now we have molecular alterations for the first time, right, that can be used to assign a WHO grade 3 to a particular meningioma. And those are third promoter mutations and homozygous deletion of CDKN2A, similar to the IDH mutant astrocytoma. Now, if you look at the WHO, right, 4th edition was released in 2007. There was a revised 4th edition in 2016. And the reason this was a revised 4th edition, it was not a 5th edition, is because the WHO books are released as a series for all the organ systems. And you cannot release a new edition until all the other editions for the other organ systems have been released. So they all have to be at the same level. So at the time, it was not possible to release a 5th edition for the brain tumors because some of the other organ systems were still behind in the 3rd edition. So they decided to release a revised 4th edition and then wait until 2021 for the 5th edition. So it takes a long time for the WHO books to be updated. Because of that, there was a consortium created in 2016, the consortium to inform molecular and practical approaches to CNS tumor taxonomy, not official WHO. It's called C-IMPACT now. And the goal is to release information at a faster rate than the WHO books can be updated. Many of the members of this C-IMPACT Now committee are involved in the WHO series, and a lot of the C-IMPACT Now recommendations will become WHO criteria for tumor diagnosis. They have released 8 updates. You can go in PubMed and find these updates. The most recent one is number 8, and it deals with meningiomas. It was recently released earlier, a few months back in August. So I'm going to tell you a little bit about some of these updates in terms of brain invasion, third promoter mutations, and some of these other alterations, and how this impacts the grading of meningiomas. So brain invasion, is when the meningioma cells invade the brain parenchyma. It's not always easy to determine if there's brain invasion or not. And now the recommendation is, if there is possible brain invasion, but not definitive on histology, do molecular testing. And then depending on what the molecular alterations are, assign a WHO grade 1 or a higher grade to the tumor. So basically, if brain invasion is ambiguous, you let the molecular alterations decide. Tetramer mutation on CDKN2A/B alterations are associated with grade 3. Overall, there's a small percentage of cases that we have these alterations, so it is not recommended that we test every case because most meningiomas would be a WHO grade 1. So the recommendation is to test higher grade meningiomas, grade 2 or grade 3 meningiomas, to confirm either the higher grade 3, or if it's a grade 2 tumor, to exclude the possibility of a grade 3, by excluding these alterations. The same dilemma of homozygous versus hemizygous deletion that I mentioned earlier for astrocytomas IDH mutant applies to the meningiomas. There's evidence that shows that homozygous CDKN2A/B loss and tumors with hemizygous deletion show similar behavior, but hemizygous deletion is not official grading criterion at this time. Here is some of the data to support that use of TER promoter mutations and CDKN2A/B deletion for the higher grade designation in meningiomas. And then again, similar to the IDH mutant astrocytomas and the glioblastomas, these 3 genes are frequently deleted together. So you can use immunohistochemistry for either P16 or MTAP. P16 is the protein associated with the CDKN2A gene, as surrogate markers for CDKN2A/B status in meningiomas, right? It's a cheaper and faster way to evaluate CDKN2A/B status by using immunohistochemistry as a surrogate marker in meningiomas. Loss of K27ME3 signal. This is the same alteration, similar alteration that we see in diffuse midline gliomas, right? Loss of trimethylation at this residue in histone 3 is predictive of recurrence in WHO grade 2 meningiomas, but it's not. It has a prognostic role in the grade 2 meningiomas, but it doesn't currently inform the grading. So we do not assign a grade based on this alteration, but it is recognized that in grade 2 meningiomas, tumors that have loss of K27ME3 signal have a higher rate of recurrence. We have mutations in SMARCE1, which are associated with clear cell meningioma. So virtually all clear cell meningiomas will have SMARCE1 mutation. So this is associated with a WHO grade 2. And we have BAP1 mutations and PVRM1 mutations, which are associated with papillary and rhabdoid histology. These tumors are almost always higher grade, 2 or 3. But then again, there's no specific grade assigned on the basis of these mutations yet, but these things may change, right, as data accumulates and the new WHO is released in a few years. Now, something that is recommended now based on the CE Impact Now update is that meningiomas that have 1P deletion, right, in addition to the loss of 22q or NF2 mutations, which are very common alterations in meningiomas, 22q and NF2 mutations. So an additional 1P deletion is enough to assign a WHO grade 2. Or at least that is the recommendation of the CE Impact Now. The meningiomas that have the 1P deletion are assigned a WHO grade 2, even in the absence of histologic features to support a higher grade. And I'm going to finish by talking a little bit about DNA methylation profiling. We're close to the end. I have like 2 more slides. There's a new tumor entity that is defined by its unique methylation profile. Right? This highlights that change of how we think about brain tumor diagnosis in the WHO. Now we have this tumor that is defined by its unique methylation profiling. It's called high-grade astrocytoma with pyloid features, HGAP. The histology overlaps with high-grade pilocytic astrocytomas and glioblastoma, so it has similar histology to high-grade pilocytics and glioblastomas. MAP kinase pathway alterations, homozygous deletion of CDKN2A/B and ATRX mutations are frequent mutation alterations in this tumor, and they usually occur in the cerebellum. So in the setting of a glioma or a high-grade glioma in the cerebellum, you must consider this entity in the differential diagnosis, and it is defined by its unique methylation profiling, so methylation analysis is probably recommended in that setting. Now, methylation is very useful for brain tumor diagnosis, depending on which classifier you look at. There are about 193, methylation classes of brain tumors. This continues to be refined, and we continue to utilize it. Not on every case. It's very helpful in tumors that are ambiguous by histology or that have an ambiguous mutation profile. But it's certainly a very useful tool. You can apply this to meningiomas. You end up with about 6 classes of meningiomas based on methylation analysis. And for the most part, the mutations correlate with what I just mentioned in terms of the alterations that are associated with the methylation classes that are benign, methylation classes that are malignant, equivalent to a grade 3, or methylation classes that are intermediate, equivalent to a grade 2. So you could use methylation also as a way to stratify meningiomas. If you take a cohort of meningiomas diagnosed by histology, you can apply methylation profiling, and you'll have a small number of cases that were assigned a WHO grade 3 by traditional WHO criteria, but they actually match to a benign meningioma class. Or you also have meningiomas that were assigned a grade 1 by WHO criteria, but then match to a malignant grade 3 class. So it's a way of refining the diagnosis of meningiomas in some cases. Now, just to summarize, molecular characterization plays a very important role in the diagnosis of grading diffuse gliomas, also meningiomas, some other tumor types. Methylation profiling is a very useful tool in the classification of CNS tumors. And the incorporation of molecular alterations in diagnosis and grading is expected to increase in future editions of the WHO classification as we gather more information about how particular mutations can be used to stratify patients more accurately. And I'm happy to take any questions. I want to acknowledge some of the other neuropathologies in our group. Some of the slides that I show were actually donated by Greg Fuller in the past, who recently retired. Jason and Maria, who are fantastic colleagues.
Thank you. Thank you so much, Dr. Ballester. This was amazing. We can answer some questions from some of the panelists. I just want one question. Obviously, in the ideal world, everybody wants to have NGS and methylation for every case. But practically speaking, and considering the cost of these tests in the real world scenario, not only in this country, but in any other country where resources are limited, can you tell us what will be a couple of tests that would be informative, that would be key, so that the oncologists or the neurosurgeons will guide treatment better, that are reasonable to do, rather than having 300 or 500 gene panels?
Yeah, so that depends, right? In some cases, you do need the 300 or 500 gene panel, or you do need the methylation. We always try first immunohistochemistry, right? We always try to arrive at the diagnosis and the grade with immunohistochemistry, which is faster and cheaper than the other tests that we have available. Now, I think that's where the role of the pathologist comes in place, right? You're sort of like triaging cases in a way. Here's a case that I can diagnose with the information that I have from imaging, age, clinical presentation, histology, and immunohistochemistry, and you recognize those cases. And then you also have to recognize the cases where you need additional testing. And that is a way of, to some degree, control how many cases you send for sequencing, how many cases you send for methylation profiling. And I think that's how we spend a lot of our time, right? Is deciding which cases require the expensive additional testing and what cases do not. It's not always straightforward. The mutations keep evolving, and then we have new alterations that are associated with grade. So it's a constantly evolving scenario. You just have to be on top of the literature and follow the most current guidelines.
Leo, nice job. I had a question. Intraoperative diagnostics is kind of a hot area right now. Do you see us in the near future being able to do these tests while we're operating, getting diagnoses to guide our surgeries as neurosurgeons?
Yeah, so basically, if you need a molecular alteration or a mutation to define the tumor type, then you need to be able to do that rapidly in the time frame of a surgery. Or the current time frame for intraoperative consultation is about 20 minutes, right? That's our goal. It's very difficult to do any type of molecular characterization in 20 minutes. Now, do you have to do it in 20 minutes? If you do it in an hour or two, will that still be useful to guide surgery? Maybe in some cases. There are some rapid PCR tests that can address some of the alterations. There's some literature, for example, you could do rapid IDH1 testing in 1 or 2 hours. So that's feasible with the tools that we have currently. That's not used widely. It's expensive. You have to change a lot of the workflow, but it could potentially be done in some cases. But it's limited, right? I think having a large panel with 500 genes in a matter of a few hours is not feasible. So you could maybe target some things and identify, situations where a particular mutation may be useful intraoperatively, and perhaps design a rapid assay to address that particular scenario. But then it becomes very customized and becomes expensive, labor intensive to be so specific to cover particular scenarios of rare tumors. So it's not something that we're doing broadly. If you ask me, liquid biopsies is one way of addressing this, right? You could do it pre-operatively before you do the surgery and take a blood sample or CSF sample or some type of fluid and do molecular characterization. That's technically possible. The rapid NGS assay where you can look at 50 genes, 60 genes in a matter of 24 hours. So that I think is more feasible to do it pre-operatively with some liquid biopsy approach, more so that, intraoperatively or while the surgery is taking place.
Hey, Leo, excellent presentation as always. I kind of want to follow up on Yoshua's question about the decision to go from the cheaper immunohistochemistry to something that's more next generation. Like, for instance, IDH antibodies are very specific, they're clean. But then what clinical scenarios would push you to go, say, the IDH staining is negative, you want to still dive deeper into whether this is potentially high grade? Are there clinical contexts that will drive you to go for more sort of like next generation sequencing to look for maybe other types of IDH mutations? And in meningiomas, also comment on the P16 mutation as well. If it's negative, what would drive you to do something more, targeted or more next generation sequencing?
Yeah, so for diffuse gliomas, the IDH1, the antibody recognizes the canonical mutation, IDH1R132H, is present in about 95% of the cases. That covers most of the scenarios. Now you have the non-canonical mutations. So in patients that are younger than 55 years of age, the recommendation of the WHO is that you must evaluate the presence of these non-canonical mutations and the only way that we can do that currently is by sequencing, right? So in patients that are younger than 55 years of age, in order to exclude IDH1 or IDH2 mutations completely, you must do sequencing. Patients that are older than 55 years of age, you can use the immunohistochemical stain to exclude IDH1 and 2 mutations because the frequency of those mutations occurring in older patients is much lower. So there's a risk, right? And there are patients that are older than 55 and have IDH1 or IDH2 mutations. You can find rare examples of that. But for practical purposes, we use the immunohistochemistry alone to exclude the mutations. In meningiomas, I think currently, and this C-Impact Now 8 recommendation was recently released, and things may start to change on how we address the molecular testing in meningiomas. But for the most part, we don't do frequently molecular testing in meningiomas. We do the traditional grading based on histology. If the higher meningiomas, grade 2 or 3, we've been doing some sequencing in those cases. MTAP is useful in our experience as a way to perhaps exclude loss of CDKN2A/B. P16 has not worked very well in our experience. There's some literature that suggests that P16 can work. It hasn't worked well in our experience. So you could use immunohistochemistry for CDKN2A/B as a surrogate marker. I think MTAP works better than P16, at least that has been our experience. And then you confirm the loss by FISH or sequencing or some other test, so you're narrowing down the number of cases where you need to do that additional testing. But now with the 1P deletion, right, the only way to do that is by array or by a large next generation sequencing panel. So I think we're going to have to start, the way things are going, the meningiomas will also require additional molecular characterization, in particular to address this 1P deletion status, because we don't have other ways of evaluating that currently.
Great talk, Leo. Sorry, Ashish Shah from Miami. Just had a quick question, just regarding the feasibility of in-house testing for, KRAS. I know, UCSF, and I'm pretty sure you guys do have your own in-house testing, and we send all of our samples out to KRAS, and it takes, sometimes up to 4 weeks to get that result back. And for a patient who is dependent on the KRAS diagnosis, integrated diagnosis to determine grading, I just feel like it's a little long, right? So I just don't know, what's your turnaround time for the in-house testing, and how feasible is it to establish those?
Yeah, so turnaround time is always a controversial point. Next generation sequence. So there's some limitations to the assays, right? So technically, there's only you can only go so fast because the steps require incubations and things like that. For example, methylation profiling, the wet bench part takes about a week. You cannot go faster than that. And then you have analysis and all of the other things. Next generation sequencing, it's in the same time frame. I think our average turnaround time, we're constantly trying to improve that and reduce it because all the physicians are interested in that. I think that our current average is about 2 weeks or a little bit less than 2 weeks. In-house testing is usually faster than sendouts, but then you have to balance the cost. And then not every institution has the resources or the volume to justify in-house testing. Is kind of expensive, and it's one of those things where batching and having a large number of samples helps with the cost. There are some rapid assays that are available. So fast next generation sequencing, there are some instruments that are available that can do that very quickly, right? 24 hours turnaround time. But then you're dealing with smaller panels. But in some instances, that's all you need, right? In some instances, you don't need 600 genes. There's a handful of genes that we know for the most part are important, and you could have a targeted panel, small panel, in one of these rapid next generation sequencing instruments that can give you an answer in a matter of 2 days, for example. And that may be one way of accelerating next generation sequencing results in some cases. Now, that still requires equipment, personnel, establishing a workflow in a laboratory, but those are certainly possibilities.
Thank you.
Well, in order to respect everyone's time, I really appreciate for you giving us this excellent update on everything that's happening right now. And we're going to have our next webinar in a couple of weeks with from Germany, Philip Koshnia, who's done a lot of work on the random resector. So hopefully we'll see a lot of people on that one. And thank you everyone for joining. And as we mentioned before, it's going to be recorded and available for everyone. Thank you so much.
Thank you, everybody.